Go ahead. Come on in. A beautiful afternoon and welcome. Welcome our residents, our friends from Buffalo, Board of Trustees members, staff, our former medical director, Dr. Mahoney, to what will, I know, be a very informative afternoon. We're gathered here today because of a very special person. Mary Jo Montani, who is a beloved resident, who was a vibrant member of our community until she passed away in April of 2019. Her large, loving, and incredibly devoted family continue to be amazing supporters of the Boston Home Mission. The Montanis will always be family. Mary Jo's brother, Larry, is the chair of the University of Buffalo Neuroimaging Analysis Center Advisory Council, and there will be a prize for anybody who could say that 10 times fast. And Larry was determined to introduce the Boston Home to researchers in Buffalo. Later in 2019, Larry arranged for Dr. Zivadinov and members of his team to visit. The energy and the enthusiasm in that room during our initial meeting was magical. We all knew that something groundbreaking was about to commence. Without Larry's passion and prayers that someday a cure for MS will be found, we would not be here today learning about phase 1 of the CASA-MS study. It is truly an honor and a privilege to introduce Larry Montani.
Christine really did my credentials with that. Thank you for such a warm introduction. And you know, it's a joy to come back to the Boston Home. My sister was a resident 12 and a half years. And there were often family visits, and we got to know the residents and the team that makes this a home over those years. And being engaged with the MS community in Buffalo, where I lived and raised our family. It was natural for me to try to bring the talents of the Buffalo Neuroimaging Analysis Center here to the Boston Home. As a mission moment, if you will, I wanted to help the researchers, you know, just stay connected to the most advanced cases of MS, and just to help them realize the importance of their work that they were doing each and every day. So what I had envisioned as a mission moment turned out to be much, much more. Once Dr. Zivadinov and his team were on site, got to engage and meet the residents and the staff here at the Boston, holistic care that they provide. So it was to their credit that we're able to present their work and their outcomes to date, to offer insight about what's to come. But I want to express how important it is that the residents of the Boston Home are champions in all of this. Without them embracing the opportunities that they saw, once Dr. Zivadinov suggested there could be, you know, research opportunities here, it wouldn't happen. It's a big change to the Boston Home, and credit Christine and the leadership for embracing the challenge of opening this home to research, but to the residents that fully embrace the opportunity to participate and undergo the challenges that it means for them as individuals to participate in this research. But I'm confident with Dr. Zivadinov and his team. They do quite novel work. They do exceptional work. They are leading new grounds in the research of MS. They are following pathways to the most advanced cases of MS, as you all live, work with each day. And I think, and I believe that by following those pathways to the most severely affected, that they will find pathways to a cure. And that's their mission at Buffalo Neuroimaging Analysis Center. It's not just to do research to fill drawers. It's to do research to find a cure. Without further ado, I'd like to introduce Dr. Robert Zivadinov.
Okay. So thank you for being today. I want to first recognize our primary audience, which are people with multiple sclerosis and especially everyone who participates in research studies. Without you, nothing is learned. CASA-MS participants at Boston Home and in Buffalo, Boston Home collaborators, BNAC Advisory Council, who provided and raised over $500,000 for this pilot first study. All the donors, especially the Montani family, who support in memory of Boston Home resident Mary Lou, inspired this study. Some of the research team with us today from Boston Home, Alex, Christine, from Buffalo, Dan, Ferdinand, Cheryl, Mike, Niels, and others. I could go on, but I want you to hear about the results. The slides I will show you are similar to those that I would use in any scientific meeting, but I will try to do my best to explain in lay terms what they mean. And the Advisory Council of Buffalo Neuroimaging Analysis Center is helping us to communicate our findings to you, the people with MS, and that are seeking for the answers. So let me know at the end how I did. There will be also time for questions, and those who are on Zoom, they can put the questions in the chat too. We'll try to answer most of the questions today. And with that, I will hook up again my presentation. Showing?
Yeah. Thanks, Greg.
Great. So you can see the name of this project is Comprehensive Assessment of Severely Affected Multiple Sclerosis, or CASA-MS. I don't know if you are familiar, but in Italian, the casa means home, right? So we wanted to find a term that would resemble what's happening in Boston Home and to be fitted with the study, which is CASA-MS. Our goal was really to investigate predictors of what brings to this severe progressive form of the disease. No one has been before looking for that. These are some of my disclosures. I have been involved in research for many years and funded by most of government organizations as well as industries and private and other organizations, including foundations. What I want to talk today are several points. I want to give you a lay brief overview what MS is and talk about things probably that you did not hear about. Then I would like to introduce the topic of severe progressive MS and what are the issues why it has not been characterized. Then I will present you the phase 1A findings of the pilot study that have been published in 3 peer-reviewed papers in eminent journals that you helped with your participation come to the really being published out. And then what is the future for the bringing this research even to the highest level. So you can see here, brain has 2 compartments. It has the white matter, which is this, and it has gray matter, that's this. So one of the things that we know is very characteristic for multiple sclerosis is that patients very early develop white matter lesions. And so you can see these white matter lesions grow, and probably in the first 10 to 15 years, every new of these lesions is bringing a new level of the disease. What cannot be seen on a normal MRI scans clinically, neither the ones that we are doing in everyday practice, are these gray lesions. You can see here these green lesions that are called cortical lesions. You can see there are different types of these cortical lesions. But what these lesions are responsible for over time is the development of gray matter atrophy. So basically, these lesions develop that the cortex shrink. So does the deep gray matter and specifically the thalamus. As the disease is going on, there are a number of processes happening, but one of the ultimate paradoxical processes is that there is more atrophy in the brain of MS patients and in the spinal cord. And because of that atrophy, these lesions get smaller, right? So, or they really disappear. And I will show you that on some scans a little bit later. And obviously there is more damage happening over time, and there are positive processes that are trying to limit the damage. So, conventionally, we usually do in a clinical real world 3 scans. T2 weighted scan for detecting T2 lesions, one in the middle. Then when we give you the dye contrast on T1 to see active lesions, and then on the T1 without those lesions. That's done everywhere in the world, including in all the clinics in the United States. In the last probably 100 years, but specifically in this era of technology boom, there have been more invention being made, including invention of high field scanners, 3 Tesla, ultra high field scanners, 7 Tesla, and ultra low field portable scanners, which are 0064 Tesla. Those are better in recognizing these lesions that you can't see on conventional MRI, those green ones that are invisible on conventional imaging and that we call cortical subpia lesions. Also on those scans, you can see lesions called pearls, paramagnetic rim lesions, which you cannot see on normal scans. And then part of the lesions, as I say, is going into atrophied lesion volume or disappearing. So as a result of this white matter and cortical lesions presence in the brain and spinal cord, there is atrophy developing in very different parts of the brain and leading to the main cause of disability development. Brain atrophy and spinal cord atrophy are probably the most important indicators and predictors of conversion from relapsing remitting to secondary progressive MS. This is a paper that we published in Lancet, and we are now saying that in addition to conventional imaging and new McDonald criteria that were presented a month ago in Denmark are now including requirements to do the cortical lesion detection and to do paramagnetic rim lesion detection. And hopefully things are going to move from here, but still we are in most of the clinics at the level that I showed you, just doing T1, T2, and T1 with GAT. On the same time, there is really a timing of about 30 years from when you even don't have a first symptom, and that's called radiologically isolated syndrome. So you do an MRI because you have a headache or because your relative has MS, and you find that you have a lesion typical of MS. So you never had a clinical symptom, but you did an MRI, and that's highly indicative of multiple sclerosis. So from here to severe progressive MS, there is a long way, but in some patients, not. some patient can early really reach that level of severe progressive MS. And I will be speaking in a moment about that. But usually the patients get a first clinical attack, which we call CIS. Then they have relapses over a period of 10 to 15 years. Then they have a transition between 5 to 10 years between relapsing and progressive disease. And only a portion of patients with progressive disease are reaching severe progressive MS. It's about 10% of patients with multiple sclerosis, and you have severe progressive MS. Unfortunately, if you look any classification of multiple sclerosis and criteria currently available, severe progressive MS does not exist, right? It's not in the textbooks. It's something that we know is affecting small amount of patients, but really it's not part of the diagnostic criteria. And to give you an idea what does that mean from a clinical point of view, people in this scale called EDSS, or Expanding Disability Status Scale, at level 0 can run. At level 3 can only walk. At level 4 to 6, they walk with some difficulty, and the level 6 definitely with a cane. At level 7, they are in the wheelchair. At 8, they are mostly, bed-driven, and at level 9 and higher, they are confined to bed. So clearly, above level 7 of this scale is what we refer to as severe progressive MS. So let me tell you about why it's important to study severe progressive MS. Because the course is unpredictable. When disease starts, we don't know whether somebody is going to be good for the next 40 years or somebody in less than 10 years is going to get to that stage. And at the moment, it's very difficult to find out what's really the driver of this. And if you think, there are really two types of aggressiveness. Those with early aggressive disease, and this is important, those who in less than 10 years from first symptom or less than 40 years of age already reach that level of 6 on EDSS, which means walking with a cane. That's called early aggressive disease. And then those who reach that same level or higher, but it takes more than 10 years and more than 40 years of age, 10 years of disease duration. So although the definition does not exist, we refer to severe progressive patients as those who are 7 or above 7 of EDSS, who need comprehensive part-time or full-time care with either their own homes or in nursing facilities, as this one is. And the reason why you are under-researched population is because there is no consensus currently on what the definition is. It's not part of diagnostic criteria. There are no specific management and treatment guidelines. We don't know what's better to do for you, this drug or that drug. We just don't know that. And there are really practical difficulties, logistic difficulties in studying population like you, as I will refer further. And maybe that clearly was okay until we didn't have the drugs that may change your lives. But now, with introduction of more effective drugs that are not just tackling inflammatory component of the disease, but begin to tackle neurodegenerative component of the disease and potentially remyelination, which means bring you back from the current state to a better state, it is very important that we define how your disease evolves at any time from when you reach the severe progressive MS, and how we really can design the trials based on that endpoints and evolution for the future if such drugs are to be available. So, in large, your type of the disease has not been characterized. If you ask me before this study, did we know that you have this severe disability because you have more white matter lesions that I showed you, or cortical lesions that I showed you, or because of atrophy of the whole brain or part of the brain, or because of the spinal cord? I can tell you, we really don't know, right? We know that everything is kind of contributing, but don't know exactly which one of the components to specifically goes against. And the second thing is that we had, when Larry brought us here, I'm researching MS for more than 20 years, and I strongly believe that that gray matter part, the green lesions, right? Cortical atrophy, gray matter atrophy, that's the one important for high disability and early disability in MS. And so our hypothesis for the studies was that independently, if you reach that severe progression early or late, it's going to be that gray matter that's leading it. And so we embarked with the help of Boston Home on a first such of a kind study, which was in many ways epical study. And only thanks to the Larry Montani and the BNAC Advisory Council, we got the courage to embark in something like that. They also helped us, to bring information more down from research to a lay language point of view, and really engaged in publishing papers, which is quite unique because patients with MS never publish the papers by themselves, but this council did it. So hopefully we can engage the council with the story of the CASA-MS also to try to bring in lay language the data that I'm showing you here. Let's not forget one thing. This effort was heroic because at the time, go back in 2019 to 2022, when this data were collected, right? There was a unbelievable pandemic ongoing in this country, and more so in Boston Home, which was on lockdown, more than being free to visit, right? So we really, thanks to all the staff, residents and others who really helped this happen, and including our own staff. And what was the design of the study? The design was to take 53 patients from residents here at Boston Home who had 7 or more than 7 of EDSS, and to match them with the people from Buffalo who had same age, same sex, and same disease duration, but with lower disability. Don't misunderstand me. They did not have benign disease. All of them had secondary progressive disease that I showed you in one of the slides. So they have been progressive patients, but not as severe progressive as you guys here, although they had very similar demographic characteristics. So that was the design that we thought would be the best to study why some have this level of disability and some others do not. The study was done at Boston Home at University of Buffalo, and it's first of a kind in the United States, and I would say in the world. And we wanted to have a large amount of sophisticated testings that will give us the answer. So this is a simple table showing who participated in the study. I'm repeating, 53 people from Buffalo, 53 people from Boston, mean age 62, mean disease duration 28. The Buffalo people had much lower EDSS, but still very high, 6 versus 8 at Boston Home. and they were in general similar to other findings. This study was a pilot study. As such, we couldn't ensure that all MRI scans are acquired in standardized way on the same scanner. And that was one of the limitations in this first study. While all the scans in Buffalo were on the same scanner. And because of that, we used some of the measures that are very resilient to changes of the scanners, like, for example, lateral ventricles, which are proxy of whole brain gray matter atrophy, medulla oblongata, proxy of the spinal cord, disconnectivity of network efficiency that gives us an idea how the networks are really resilient. And we published, as I said, 3 studies. The first study was published this year in Journal of Neurology, very prominent journal in neurology. And on the left are the scans of the patients from Buffalo. On the right are scans from Boston Home. And the first question was, are you different from them in terms of your visible lesions? Very surprising to us, there was no difference in amount of lesions that we see on these conventional scans in your brains respect to those in Buffalo who had much less disability. So how is that possible? What drove that? Then disability. But if you look at the second part of this image, you are missing a little bit brain here and on the edges, which means a cortical atrophy, right? So there is probably a pathology in the cortex that led to development of that cortical atrophy and that shrinked your brain. And indeed, the difference in cortical volume between Buffalo and Boston was the most strongest finding that we found as a difference between you. The second one was thalamus, and the third one was disconnectivity based on where the lesions were located. Do not forget that I mentioned that in the second part of the disease, some of the lesions are shrinking because atrophy is happening, right? Could be that because you had more aggressive disease, that part of the lesions are not visible anymore on the MRI scans because they just underwent complete destruction, including with the other tissue. Then we asked ourselves a second question, but if we go and pick up the worst cases from Buffalo, who did not have this level of disability, but some people had very high level of disability, would they show similar brain findings as the Boston Home people? And they fell in this blue cluster, which is again people with more cortical atrophy, more thalamic atrophy, and more disconnectivity. So that was the second revelation to us, that actually the Buffalo people, those more aggressive, are not so different from people in Boston Home. They have very similar characteristics of gray matter damage. The second paper was quite unique because it's based on a cognitive test that has been developed in collaboration with University at Buffalo investigators, specifically for population like you are, who cannot use your hands or who have trouble with vision. And so you cannot really correctly, answer on most relevant test for multiple sclerosis for cognition, which is single-digit modality processing speed. So what we did, we developed ATOPS. What is ATOPS? ATOPS stands for Auditory Test of Processing Speed, which means you don't need to use your hands. You need not to use your eyes. You just listen And based on that listening, you give verbally the answers, and we create a processing speed from that. And you can see that in CASA-MS study, only 65% of Boston home people were able to fulfill the main examination as DMT, respect to 100% of Buffalo cohort. But when it comes to ATOPS, actually both cohorts were very similar, over 95% able to accomplish. So now we have developed in CASA-MS a good cognitive test that can be done by people like you and then follow over time to see how it's changing. The difference in cognitive behavioral skills on both ATOPS and SDMT, as you can see here in blue and red, was similar, and they correlated both very well, again, with this cortical atrophy and thalamic atrophy, which was our main finding on the imaging. The third paper was published in Multiple Sclerosis and Related Disorders. It was a really publication about what is the best scale to look how you evolve over time from a motor point of view. As I showed you, the EDSS at the beginning, between 7 and 9, you are pretty much not able to walk. We cannot test your walking skills. You are fully in a wheelchair or really driven to bed. So how I really make a difference if I give you a drug, whether you are improving or not, if you cannot walk, right? So we employed very sophisticated scales, including Scripps Neurologic Rating Scale and combinational Y scale to a disability level like you have, those which are used in stroke or for patients with advanced tumors of the brain, etc., so that we can better understand the changes that are happening. And in this study, we showed that both Scripps Neurologic Rating Scale and CombiWise were the two most important and sensitive scales to understand your level of disability, and that correlated best with MRI outcome. It's probably that should be used in the future studies. So what are the lessons we learned in CASA-MS? First, that your phenotype is characterized by gray matter atrophy, cortical and thalamic. That we need further prospective studies, which are very rigorous to test the differences. We also understood that you need unique tests to be used for your level of disability, like ATOPS, Scripps Neurological Rating Scale, and CombiWise test. We also understood that we need to do longitudinal studies to see how these scales are evolving, because CASA-MS was the cross-sectional study. And most of all, what we learned is very important, and these are the logistical barriers that you have when entering in any study. I fully appreciate and understand your willingness to do in the study, but imagine now, I said that this morning, if you need to do all this, you need to do an MRI, you need to do optical coherence tomography for your eye, you need to do empty testing, you need to do clinical examination, you need to, how many times we need to take you to the hospital to do all of this, and this feasible, right? And you need an ambulance to take you for an hour and bring you back. So to me, the only what makes sense is that we need to study you here. We need to do research studies with you here. We need to develop technologies that will be used here and not in some hospitals. And that is what I think our research is going to be about in the future. How to adapt AI, artificial intelligence, and technological advances so we can bring advanced technology to you and perform the studies in environments. That brings me aggressive disease. I mean, some people still get very early to that aggressiveness and some later. I don't know what's driving that. Second, we need to understand better using 7 Tesla MRI, those very ultra high field MRIs. Do you really have more cortical lesions, you know, that I showed you, those green ones, and that's what's causing the cortical and gray matter atrophy. We need to do longitudinal examinations so that we see how much you are deteriorating each year on those scales like COMBI-wise, like script, like autopsy. And that's all. And then finally, we need to use portable tools. How many of you know that there is now a portable MRI? I cannot put it in my pocket, 2 of you, but I'm going to bring it with the truck in a month here, okay? So Hyperfine is coming to Boston Home in 1 month. We have it in Buffalo. We purchased it especially for the purpose of collaborating on this study. We are already doing scans in Buffalo, and you are going to have a portable MRI here for this next phase of the study. We are also partnering with an industry called June Brain, which developed a portable OCT device, something that you put like those Meta or Apple, you know, headset, VR headsets, so that it can directly read your thickness and all the retina and retinal layers, and without any of your interaction, determine how much cells you lost. And we want to do that longitudinally so that we can start then the trials based on the data. And so how we are going to do that? I foresee 2 studies. The one is going to be a very quick study called phase 1B of the CASA-MS. It will be again a study between University of Buffalo and Boston Home, 24 people who participated in phase 1 and 16 from Buffalo also that participated. We will repeat similar tests that we did in phase 1, demographic, medical history, MP testing, and blood. But we are going to add this headset, portable headset that will also examine your eyes. We are going to bring this portable MRI, that's a portable MRI. And by the way, you can look here, you are out of the scanner, so no claustrophobia, no being somewhere that you will sit like this, right? You just put your head and all your body is out of the scanner. Also, very important, no contraindications for that type of scanner because all the pumps you have and things like that, they are really out of this. You can see, look, this orange, that's called the Gaussian field. That's where the magnetic field is. It's all above from here, right? So the field is just here. It's only 5 feet, right? It's not affecting your lower body. And with use of artificial intelligence, you can see here, this is the native scan that comes from that ultra low field scanner. We can get these scans as good as the 3 Tesla. And we are doing a study with Pittsburgh, and with your study that I'm going to mention on a 7T, we will even make this ultra low field scans better using artificial intelligence. The second part of and this will happen in the next month and a half. We need that because of the phase 2, where we need to have a preliminary data because the reviewers of the grants we submitted are questioning whether you can enter in the scanner, whether the scanner is comfortable for you, whether the scans can be done in population like you. I think it's, you know, a realistic request. But we want to drive you to the Massachusetts General Hospital, where under the supervision of our collaborator, Caterina Maniero, you are going to obtain a 7 Tesla scan. and where we can see these cortical and paramagnetic lesions better. And it will be one time only, and the Buffalo patients to be on the same scanner will need to fly from Buffalo. So while we can do the hyperfine, driving the hyperfine scanner between the two cities, we cannot drive the 7 Tesla scanner between the two cities. So the 16 Buffalo patients will need to come to Buffalo. Based on this data, we are going to resubmit the grant to the government agencies, and hopefully we will be funded soon to start the phase 2 study. It has a very similar design to the phase 1B, but this time we want 30 patients, 30 residents with early aggressive and 30 residents with late aggressive disease. And with Alex, we worked and ensured that we have enough recruiting resources between your resident, home, as well as day clinic to meet these numbers of 60 people and 30 controls from Buffalo. And those people are going to get the same tests, same demographic and health screen tests, questionnaires, MP testing, blood, optical coherence, tomography, and hyperfine. And this time, that's going to be done not just at baseline, but it's going to be repeated at 18 and 36 months, so that we can see how much you are evolving longitudinally and power the future clinical trials based on this information. So in conclusion, I would say with your help and help of Buffalo patients, we are going to, we learned unprecedented insight into severe progressive MS so far, specifically understanding the logistical barriers and how we can overcome them with thoughtful designs. I think you did a heroic effort. Really, there is not enough we can thank you for and express our gratitude, respect to what you contributed. But and I hope, as I said earlier, that really the phenotypic diversity and progression of severe progressive MS will become part of the future MS phenotypes definitions. We will work with you, refine and the technology we want to use and adopt to be used in the studies like those, like yours. And I think this will really, when this is accomplished, the next phase will be to start possibly clinical trials that can change substantially your current level of disability. You know, everybody's asking me always when I make such statements, am I going to walk again? I don't know, but I can tell you that I want to be sure that I'm reproducibly measuring how much you are improving or remaining the same respective 6 months, year, 2, 3, 5 years from now, because that's the most difficult thing, right? And if you can improve, then yes, the best one to measure that. There is a lot of people at the end to talk, to thank to. First of all, everybody in Boston Hall who made these studies available and who will still work with us in the near future to obtain this data, which is substantial effort. The council and that solicited so many funding sources, including Jacquemin Family Foundation, the Annette Funicello Research Fund for Neurologic Disorders. I would like also to thank particularly Carol Schumacher, who helped with some of this and really always was on behind the BNAC to do such inventive and revolutionary studies. Some pharmaceutical industries like EMD Serono, Biogen, Bristol Myers Squibb, who helped us with monetary funding, and Octave helped us collect, produce very sophisticated proteomic data that's still not being published. And then many private donors that more than 150 who donated, in particular those from Council, the family Pico, the family Saka, Penny Pennington, and everybody else that I'm not mentioning. I really apologize. I already mentioned Larry Montani. He was instrumental, and his family in all of this. And finally, I would like to thank also my staff that worked extremely hard to make this happen in a record time. And I thank also the future collaborators like those two, Martino Center at Harvard, who will be working with us on 17. And I'm happy to answer all your questions, and let me know if I met expectations to make things easy. Thank you. Any questions? Yes. So the question was whether cortical atrophy and these tools that I described that are logistically much better to be used, if we confirm that in the future studies, would that solve the problem? As I said, the 7 Tesla study is extremely important because it's going to tell us that that cortical atrophy that I showed you is because of the cortical lesions that we can't see on a normal MRI. We just can't see those lesions on a normal. So that's why that 7 Tesla component is important. And the portable tools are important because even if I have a 7 Tesla MRI, am I going to be able to do the study bringing you every time to this 7 Tesla MRI that's very expensive, that's very tough to go, that's super booked, and it's just not feasible for this type of research? And I would say no. That's why we need to show that we can recognize this cortical atrophy on a portable MRI, like the Hyperfine is, and show enough power of the potential drugs to change that rate of cortical atrophy over time. So at the end, when this is done, hopefully we will have a much better understanding that cortical atrophy is the driver of these disease phenotypes. Now, you can also ask me, but does any of the drug work on that cortical lesions? I can tell you that no official clinical trial ever tested the efficacy of disease-modifying therapy on cortical lesions. We have a study that we submitted now, but that's still confidential, and I cannot comment on that. But we are starting to test effect of disease-modifying treatments on cortical lesions, specifically because we can use also some artificial intelligence methods to produce, obviously, offline these cortical lesions. But don't misunderstand me. Even if we do that offline, these cortical lesions are just a snapshot of what you are going to see on a 17. It's still going to be 70% less than what we are going to see on a 7 Tesla. Yes.
Then you. Back in 1977. The reason I'm even that speaking is because I don't know, I would like to participate in any way I can to help with further testing. But I don't know if I'm even appropriate for that. Because I'm considered to be some to be an anomaly in that I can still move my legs, can't walk, move my hands, and there are a lot of things that I'm capable of still doing.
So the fact that you got your disease in 78, but probably you are here a couple of months, but when you became wheelchair bound, like 10 years ago or 5 years ago? 3 years ago. So you are in that group of people, second group of people that I showed, right? Which are called late aggressive, right? You are not early aggressive. You, for 20, 30 years, you were okay, right? But then suddenly, at some point, very, very quickly got to the wheelchair position. Now, that's called late aggressive, right? And so what is the reason that you were for so many years good, and then suddenly, you know, you began in a very short time to reach that? That's interesting for us to study, because clearly aging is one of the factors that's superimposing on already, you know, there is this theory, a threshold theory. So you lose so many cells in your brain or in your spinal cord, and then one more cell that you lose is going to really precipitate the disease. When I was seeing patients in Italy at the time, when I was there training, and I always remember a case of a gentleman who was a really very, very passionate skier. And I saw him like 6 months ago, and he was telling me he just returned, you know, from skiing in Italy, did all these slopes, etc. And then I see him like 6 months later, he's in a wheelchair. And I said, that's impossible. You were just skiing 6 months before. What did you had an accident, car accident? No, he said, I didn't do nothing. It just happened all at once. So he's that early aggressive person, or that he may be even late aggressive, but that transition of aggressiveness happened in a very short period of time. And so we need to understand what's that threshold may be that he was compensating. He may be, and he was having a lot of lesions in the brain, a lot of brain atrophy, but you didn't see that clinically. And then suddenly maybe one more lesion really precipitated his state. And that's bringing what actually with Christine and Alex, when we started, we wanted to research in this population, and that's resilience. Resilience to worsening, because that network connections, you may have spots everywhere in the brain, but if they are not in the right tracks, let's say, if today there is a hurricane in Boston, all the planes will be down, and because Boston is a big hub, right, for many air carriers, you are going to see the disruption of flights everywhere in the United States, right? If that happens in Buffalo hurricane, nobody will feel it, right? Because we have only 24 gates and maybe 100 flights per day, right? So it depends really where the lesion hits the network. But you can have one big lesion hitting the right network, and that's going to be devastating, right? So it really matters where the lesions are too, not just how many of them you have. Any other question? Yes. So in the first phase of the CASA-MS Unfortunately, we did not collect the data for genome, but in these studies that are upcoming, we are going to get approved testing for looking on your genome. Very few studies have been done on looking on genome, especially in severe progressive MS. And although we collected your blood, we didn't have ethical approval at that time for genetic, the whole full genome to be looked at. That requires extra IRB approval. So it will be done in the next phase. Yes. What year? What in 2020? 2020. Yeah. Yes.
Was diagnosed 1 year ago. I MRI'd me back. The one that I had. Does that mean it was fine because it wasn't because the high functioning machines? Or
That's an excellent question. So there is a type of.
you want to repeat the question?
So the question is that the lady got onset of hair disease when she was going through the menopause, and when she did the MRI, there were really no lesions in the brain. Did I say correctly? Yes. So there is a type of the disease called myelocortical disease, and when we first looked the results from the CASA-MS study, I thought, wow, maybe you all guys have myelocortical disease. Myelocorticals means that there is a lot of lesions in the spinal cord and atrophy in the spinal cord, and then there are these lesions in the cortex, which we don't see, right, on a normal MRI. And there are no many lesions in the brain that we see. But as you saw, a lot of you had lesions in the brain. So although you have a lot of lesions that you don't see, and you have some spinal cord, you still had lesions in the, that's why I want to do more sophisticated studies to understand, is there maybe a subgroup of patients, maybe like you, who did not have brain lesions, but most of your disease was just spinal cord and cortical driven. And myelocortical MS has been only pathologically described by the Cleveland Clinic group, by Bruce Trapp. And they are saying that basically these people do not have many white matter lesions.